morning. My name's Sandra Shuri, and it is really a delight for me to see you all here this year. Last year we were mighty and strong and inspired, and this year we are even stronger at the summit. Our purpose here today is to understand the nexus between a healthy life, livable communities, and the tree canopy. What I like so much about the summit and why I hope we'll be able to continue is it is the perfect mashup of people who wake up each and every morning thinking about how to improve the tree canopy with a mashing together with the people who wake up every morning trying to think about how to create a more healthy community. And we need each other, both of us, to succeed in our mission and our purpose, and it is just so great to be together. We have a great panel this morning. Our panel members are experts, they're practitioners, they are advocates for evidence-based policy development. Each of them come with scientific credentials and training. They are, most importantly, they come with a commitment to social change, because really improving our communities is one of those things you do that is in that bucket of social change and creating a better tomorrow. We have about 20 minutes for each of them to share their thoughts on different aspects of how trees play a role in building healthy, livable communities. After all three speak, we're going to take questions. So as you are listening, I encourage you to be writing down your questions, and we'll try to get a dialogue going after they talk. I think our panel is probably responsible for catching us up on the agenda time for today, but we're not going to do that by shortening our speakers' presentations. We'll do it by packing our questions in a really efficient way. I'm going to introduce all three of them, and then I'll have them come up. Our first panel member this morning is Tony Eyton. Dr. Eyton is the Senior Vice President for Healthy Communities at the California Endowment. In this capacity, he leads the endowment's really amazing 10-year commitment to building healthy communities. Prior to joining the endowment in 2009, Dr. Eyton was both the public health officer and director of the Alameda County Health Department. He earned his bachelor's degree in neurophysiology at McGill University, his jurisprudence degree at UC Berkeley's Boalt Hall, and his medical degree from Johns Hopkins University. Tony's going to lead off our panel talking with us about the notion of place and health. Following Tony will be Jeff Donovan. Dr. Donovan is a research scientist for the USDA Forest Service at the Pacific Northwest Research Station in Portland, Oregon. One of Dr. Donovan's primary areas of research is quantifying the benefits of urban trees. This is something that I know when I was a board member at the Tree Foundation, I needed the evidence. So someone like Dr. Donovan, who's dedicated so much of his professional life to this, is such a treasure. He's looked at the effects of trees on the property market, on energy use, on crime, and most relevant for today's discussion, the effect of trees on public health. He earned a bachelor's degree in biochemistry and a doctorate in forest economics from Colorado State University. Today, his remarks are going to focus on the economic impact of the urban forest. And our final panel member today is Mary Northridge. Dr. Northridge is editor-in-chief of the American Journal of Public Health. I did my training in public health, and that was what we all read. We all aspired to know people affiliated with that journal. So, Mary, it is great to have you here today. She's a professor in the Department of Epidemiology and Health Promotion at New York University College of Dentistry. She has a long-standing interest in the social and environmental determinants of health. And one of her research interests is the relationship between gray infrastructure, streets and buildings, green infrastructure, parks and open spaces, and humans. How do we interface with those two pieces of our infrastructure? Dr. Northridge earned a BA in chemistry at the University of Virginia, a master's degree in public health at Rutgers, and a PhD in epidemiology at Columbia. And Mary's going to pull our panel together in discussing the idea of resilience and communities.
Good morning. It's a pleasure to be here. I'm still running on pure caffeine, and I actually have to compress a lot of information into a relatively short period of time. So I'm going to use that caffeine. And I encourage our timekeeper to be very disciplined with me, because otherwise I will go on. So trees. I love the topic. I love this organization. First of all, you have an incredibly clear mission. I wish I had a mission like yours, because I'm going to try to explain to you what we're trying to do, and I think I've got it down, but you can be the judge of this. Okay, so I'm going to take you on a quick journey, and it's about, it's a partly personal journey about trying to discover the root causes of health inequity in this country, and sort of the way that I sort of found my way into it. And hopefully it'll tie into trees. We'll see. But the bottom line message is here is that when we talk about health, your zip code is more important than your genetic code, and it's way more important. It's not even close. I'm going to show you a quick framework. I'm going to take you through it in a minute. And the framework basically argues that if we're interested in trying to improve the overall health status of Americans and Californians and eliminate health disparities and create health equity, we have to stop focusing so much on the medical model. And we have to start looking at the environments and the so-called socio-ecological model where people live, play, work, and worship. And there's a piece of this that I think was picked up this morning in both the congressman's comments and in the director's comments about participation. It's about engagement of people, about people coming together to find collective wisdom and to work and focus on issues that are important to all of us. And that's part of our work. So place is a kind of an ethereal concept, where you grow up, how you define it, what shapes and influences your behaviors and your hopes and aspirations. And I believe that trees are a big part of that. I grew up in a very beautiful place in Montreal, Canada, a place where I felt very valued, very welcome. I never for a moment thought that all cities weren't like Montreal, Canada. I literally thought that this was the norm. It's a beautiful city. It's an old volcano. It sits as an island in the St. Lawrence River, and you can go up the hill of Mount Royal, which is Montreal, and you can have a panoramic view of the city. And it's beautiful, particularly in fall. There's a park up at the top that is beautiful. It's designed by Olmsted, the same designer of Central Park and Golden Gate Park. And it's definitely a convening point for many people in the city of Montreal. I left Montreal at the age of 22 to go to Baltimore, Maryland, to go to medical school at Johns Hopkins, and was confronted with scenes like this, and this, and this, and was actually being driven around East Baltimore for the first time when I got to medical school, and I was in shock. I did not know what I was seeing. I asked the person who was driving me around, when was there a war here? I literally had no concept for what I was seeing. It seemed to me like Beirut. And there were kids playing in and around all of this. And I asked myself then, what if that kid was me? What would I be today? And what do we owe this kid? I mean, this is not a natural environment. This is a man-made environment. We created this. We actually got together and said, let's make this place look like this. And I think because it is man-made, there are a lot of opportunities to unmake it. And I often say these things are man-made, and they likely will be unmade by the work of women. I'm sorry, guys. We tend to make the mess. I went back to Baltimore recently, this was last year, to just talk at Johns Hopkins, and I decided I had to go around with my camera again and see what it looked like. It still looks like this. This is the immediate vicinity right next to the hospital. So when I started working in public health, I'm a data file. I love numbers, and I got to be the guardian of all birth and death records in Alameda County. My colleague, Glenna Trochet, did the same thing for Sacramento County. I'm sure she's as much of a data junkie as I am, but one of the things you can get from a death certificate is what somebody died of, what age they were when they died, what their race, ethnicity was, and where they lived. And you can take those 4 points and actually profile death in your community and learn a lot about these invisible patterns that influence the way people live their lives and the fact that many of these patterns are driven by policies and decisions that we have taken throughout time. This is, for those of you who don't know, this is the San Francisco Bay Area. That's San Francisco. This is Alameda County, and it's shaped like this big boot that's trying to crush San Francisco. So you can take the death certificate and you can actually convert that boot into a map of neighborhoods. These are census tracts. There are about 150 of them in Alameda County. And what we did is took death certificates and we actually calculated life expectancy for each of the 150 census tracts in Alameda County and then stratified them according to the relative length of life that people could expect in those communities. The green areas are greater than 80 years. The yellow are between 74 and 80 years. And the red are less than 74 years. And what you see here is that premature death concentrates in certain neighborhoods in Alameda County, which was, believe it or not a shock to me because I'd been to East Baltimore, and as soon as I had the opportunity to do this, I said, I bet this will be interesting. It was a big shock to the Harvard and Berkeley-trained epidemiologists that work with me, who were insistent that this was a fool's errand and that death was random and that we would create a Christmas tree map. Well, they were shocked and actually came running down the hall, and it's a great image to imagine actually this Harvard-trained epidemiologist who can barely run, running down the hall, waving this map, telling me, you won't believe this, you won't believe this. Well, I actually believed it. But people said they didn't want to live in Alameda County after they saw that map. So we went to Seattle, King County, and asked them to replicate it, and they did the same thing, and they found the same phenomenon. Went back to Baltimore, did this. It ended up being big news in the Baltimore Sun. This is Los Angeles. This was in the LA Times a few years back. This is Cuyahoga County, Cleveland. I still love Cuyahoga County, Cleveland, because they have one of the biggest discrepancies that you'll ever find. There's a neighborhood in East Cleveland called Huff with a life expectancy of 64 years. Just think about that for a second, 64 years. Just down the street in Lyndhurst, they have a life expectancy approaching 90 years. We try to explain this difference for the most part by lack of access to health care and bad behavioral choices. And I argue that this is a lack of critical thinking skills on our part. We're smarter than this. We know that it's impossible to explain that difference based on those two variables. There are other factors, much more powerful factors that are shaping life expectancy in these neighborhoods, and we need to understand them and we need to start intervening in them. This is something that the Robert Wood Johnson Foundation did. The Philadelphia Transit System, they calculated how long you'll live based on which stop you got off on the train. You can take the map of life expectancy and poverty and you can correlate them in a simple correlation. The up axis here is life expectancy, so longer is higher, and the lower axis is the poverty of the respective neighborhood. Each of those blue dots is a neighborhood in Alameda County. As you move from left to right, you're moving from relatively wealthy to relatively poor. In an ideal world, this would be a flat line. We don't live in an ideal world. As you move from relatively wealthy neighborhoods to relatively poor neighborhoods in Alameda County, life gets correspondingly shorter. This is the death tax that we pay. And quite frankly, our work is to flatten that line. And the communities across the world, I'll show you a little bit of data quickly, that actually have flatter lines tend to have higher lines. So this is not a zero-sum game. You don't have to take life from somebody to give it to somebody else. The more equitable societies raise life expectancy for all. You see that there are neighborhoods in Alameda County with life expectancies in the mid-80s. You also have neighborhoods in the mid-60s. That corresponds to some of the highest life expectancy countries in the world. This is the world life expectancy map, if you will. And other countries like Kazakhstan, Bhutan, Azerbaijan, countries that you would think in Alameda County wouldn't have a corresponding socio-ecological equivalent. But we have Hong Kong, France, and Azerbaijan in Alameda County, and we explain that by poor behavioral choices and lack of access to health care. And it's, unfortunately, it remains our sort of dominant mantra about health, that health is about health care and people behaving badly. And so we have a lot of work to do to help people understand the role of things like trees in neighborhoods. Okay, so you can do the same analysis for the entire Bay Area, 6.5 million people. You see the same basic phenomenon. You can do it for the entire state of California, same basic phenomenon. In the Bay Area, you can actually monetize that line, that slope, and it calculates out to $12,500, buys you a year of life in the San Francisco Bay Area. If you move to Baltimore, you can get 3 years for $10,000. So if you're looking for a real deal, Baltimore is a good place to go. Some people, and I am one of them, who are nerds, recognize that that is an association. It doesn't prove cause and effect, but we do happen to have in Alameda County one of the best sources of data for this, which is an ongoing longitudinal cohort study, which is started in 1965, is still ongoing. It's following 7,000 Alameda County residents throughout their lives and trying to correlate those factors that are associated with their life expectancy and other things. And they published about 200 papers from this study, probably several in Mary's Journal. One of the findings is that those with a household income 1 standard deviation above the mean were 25% less likely to die prematurely. If you're 1 standard deviation below the mean, you're about 35% more likely to die prematurely, which almost exactly correlates with our line. So we have the best level of evidence that this is real and it's important and that we have an obligation to try to do something about it. This is the world life expectancy for the developed countries. I showed you the entire world collection of countries earlier. This is just taking that top piece of it. When you look at the world life expectancy trajectory, you see that developing countries are still on this kind of linear trajectory, but once you get up into the developing countries are on a linear trajectory. Once you get up into sort of a level of wealth where you're kind of stable and you start dying, quite frankly, of chronic disease as opposed to infectious disease and injuries, you see this kind of scattering of this phenomenon. It sort of plateaus at a certain level. And there are researchers, a gentleman by the name of Wilkinson has looked at this phenomenon, plotted these graphs, and this is life expectancy by income. So you see the U.S. to the far right towards the bottom, a relatively high income, the highest per capita income, but a relatively low life expectancy for wealthy countries. And they tried to make sense of this. There's no real pattern to this, so they actually reassembled this graphic according to income inequality. And they found that a pattern emerged, and that those countries with the greatest amount of income equality tended to have the highest life expectancy. Those with the least amount tended to have the lowest. You can do a similar kind of analysis as Wilkinson did with U.S. states. And this is looking at a composite index of health and social problems on the up axis, and then income across the bottom. And you see this sort of scattered kind of look, not completely clear what's going on there. If you plot this now by income inequality, you start to see a pattern, with those states with the highest income inequality having the highest level of health and social problems that are built into this composite index. So there's some meaning that's starting to emerge from this data. So why does living in a poor neighborhood actually make you unhealthy? This is where I think we can get to discrete interventions like tree canopy. This whole notion of allostasis, which is basically chronic stress. There are a number of factors in all of our lives. I experienced it this morning on wet roads trying to get up here in time for this conference that actually stress us. And these stressors stimulate a cascade of hormones that I'll show you in a minute. You can translate the stressors as inadequate transportation and long commutes, big traffic jams, inadequate housing, unaffordable, living in communities where you feel socially isolated and lack social capital, experiencing racism and the stressors associated with racism, having high demand, low control jobs, lacking access to basic amenities like parks and grocery stores, and then worrying about crime and its impacts on you and your family. Stressors stimulate the brain through the hypothalamus, which triggers a hormone that goes to the pituitary gland, which releases yet another hormone, which stimulates the adrenal glands, which sit right next to your kidneys. And the adrenal glands release a cascade of hormones, including cortisol. And cortisol is important, and this is where a part of the connection to trees comes in. But first, in the blue, you've got the acute stressed reaction. And this is one of the things that cortisol and epinephrine and a number of other hormones do, and that is that they stimulate cardiac output. They actually get your heart beating and intensify the ability of your heart to operate at high levels efficiently. They rally available glucose for use in case your muscles decide they need to run. They enhance immune functions, decrease inflammation, and they stimulate the growth of neurons in your hippocampus and prefrontal cortex, which are necessary for what's sometimes referred to as executive functions, basically trying to assess and make analyses of an acute situation to figure out what's the best option. That's what happens in the blue period in the acute stress. We all need it. We all use it. It's good for us. It keeps us alive. However, if we're facing constant stress, day in, day out, it never alleviates, then we get into that red box, which basically is almost the exact opposite. Cortisol has the impact on your body of sort of essentially prematurely aging you. It weathers your body. It produces cardiovascular disease. It stimulates glucose intolerance. It increases inflammation, decreases your immunity, and it actually causes atrophy in some of the key neurons that allow you to make those kinds of executive decisions. So people living in low-income neighborhoods that are constantly stressed by inadequate resources, by challenges for which they do not have responses, are living in these red boxes day in, day out, and it shortens their lives. It also actually stimulates some of the quote-unquote bad behaviors. Alcohol, drug use, eating fatty foods actually helps reduce and moderate some of the impacts of chronic stress. The argument is that when you see differences in life expectancy, disparities, you're only seeing the tip of the iceberg. You have to look underneath the surface to see all of these man-made, policy-generated outcomes that are actually very different across different populations. So I promised you this framework. I went to medical school and they taught me the medical model, which basically says, starting from the far right, if you see premature death, it's probably because there's a higher burden of disease, which is the next box. If you see a higher burden of disease, it's probably because people are behaving badly or they're just unfortunate. And the tools that we have at our disposal are access to health care, where we try to change behaviors and risk, and we actually try to manage disease. We have some levers around genetics, although we spend a ton of money trying to figure out what they are, and they tend to be relatively modest at best. And then we try to change what people know. We hand them out brochures. We tell them, don't drink, don't smoke, behave more like me, and duck appropriately when bullets are flying. And we argue that that's true, and we spend $2.8 trillion on it, so we actually have to figure out how to do that efficiently. But there's a larger story here, and it has to do with the fact that people are situated differently. They live in communities where they're exposed to much greater risk and have many fewer resources, and they're constantly stressed. And the next box over is about the policies and institutional decisions that actually create those conditions for people. And the first box is really the initial kind of birth defect of the United States, as Condoleezza Rice refers to it. We differentially value different populations based on immutable characteristics over which they have very little control. And we do it, and it shapes policy, and those policies shape the opportunities, and the opportunities put people at greater risk. That's what this cascade talks about. If you look at health disparities, they live downstream. Upstream are health inequities. You can take health out. Inequities produce disparities. You can change it to simple language. Conditions produce consequences. We spend $2.8 trillion on consequence management. We spend very little on trying to change the conditions. That's the work of the California Endowment and most public health practitioners and the Tree Foundation. We argue that you can look downstream and change the outcomes from health outcomes to educational outcomes. It's no different. The upstream determinants are the same. We have to stop thinking so much about the damage control part of the system, although we have to manage it, and we have to start figuring out what can we do upstream to try to manage those upstream conditions. At the California Endowment, we have a practice. We talk about place, we talk about policy, and we talk about narrative. We also talk about power, building social, political, and economic power and a critical mass of people who are living in inequitable conditions so that they can be enlisted to try to craft the solutions to improve their environments. Very simply, bad behavior produces disease, produces death. That's the medical model. In the socio-ecological model, a set of bad societal behaviors, if you will, biases, produce policies and practices that create neglected communities like East Baltimore. That explained what I was seeing in East Baltimore. We have interventions to try to prevent death. We call them emergency rooms. We have interventions to try to reduce disease. We call them clinics. We have interventions to try to change behaviors. We call that health education. All of those things are necessary but insufficient. We have to come up with strategies to address neglected communities. Ours is called Building Power in Place. We think that's not enough. We actually have to address policies, through health impact assessments, through looking at strategies sometimes referred to as health in all policies, to look at the health consequences of non-health policies. We think that's not enough. We have to change the narrative about what is health and who is valuable. So some of my other colleagues hopefully will talk about this because I think I'm running out of time. Green space and health. What do we know? Access to green space is associated with perceived overall general health, improved mental health, increased longevity, improved physical health and social health. We know the contact with the natural environment is actually associated with psychological restoration, improved mood, improved attention, reduced stress and anxiety, reduced aggression and reduced crime. And finally, simply viewing a green space has been shown to reduce blood pressure, heart rate, and to lower your cortisol levels. So in terms of simple, straightforward interventions, trees is good. In New York City, living in an area with good treescape is associated with lower asthma prevalence. And this study, I think, is particularly fascinating. Patients recovering from gallbladder surgery recover faster and take fewer pain medications in a room with a view of a natural scene than those in a room with a brick wall. Building healthy communities is fundamentally about trying to look at what we can do in environments to actually create environments that are much more conducive to human health. We've advertised this. We've made this very clear that this narrative about what causes health has to change. We've tried to put this up wherever we can. This is in Sacramento Airport, where all the legislators fly through, and then they call us and want to know why we're reducing property values in their districts. This was the Metreon building in San Francisco at the American Public Health Association. We have a message called Health Happens Here. I want to just end with this. Our recipe for doing this work is that you have to enlist the people who are living in these neighborhoods. You have to build their power and their ability to participate. You have to bring together the butcher, the baker, the candlestick maker, all of these various sectors that claim to be about improving the quality of life in a community. They have to work together. For the most part, they do not. Although in Sacramento, they kind of do, which is interesting about Sacramento. You guys got something going on here. I don't know what it is. We have to engage youth. They're much more urgent messengers around these issues, and it's their future that we're talking about. We have to leverage the private sector to try to bring resources towards these socially beneficial goods, and we have to change the narrative. We think that's the recipe for building healthy communities. It's about power, it's about policy, it's about narrative. And there's the slide. Thank you very much.